Good morning, everyone. My name is Asher Kornbluth. Good to see you again. What we'll be doing today is doing the GI cases for Step 3 of the boards. The format that we'll use is that I will read through the case, and then after reading through the case, we will stop at each point along the case where we think it's pertinent to the specific question on that case. Because as you read through these cases, it's very important to focus on the question that's going to happen at the end of the case. The single most important tip I will give you in the next number of hours, and when I taught all of Step 3 in the past, I would say it's the single most important tip I give you during the entire course, is that you read the cases in the following manner. The cases on Step 3 might be somewhat like this length of question, followed by the question and the choices. There's a lot of reading. And the test, as you know, is a timed test where there's pressure to do a lot of reading and a lot of thinking and a lot of answering questions. The way I have always advised people to go through these cases is the following. You read the first sentence, or if the first sentence doesn't have much information, the first two sentences, and then you go immediately to the bottom of the case where they ask the question, and then you quickly scan through the choices. All right? Because in this way, as you read through the case, you're going to have a very good idea of what you need to focus on. I'll give you a classic example that was in the released item several years ago. They had a patient, the following case. A 79-year-old woman is brought in to the emergency room from the nursing home with a change in mental status. And then I had to read this much more question. And my head is spinning. A change in mental status in a 79-year-old from a nursing home. It could be one of dozens of things. And if I don't learn to focus my thinking as I go through the case, I'm going to be lost in looking at a lot of irrelevant material. For instance, a 79-year-old from the nursing home with a change in mental status. It could be subdural hematoma because she fell out of bed. It could be one of her medications. It could be drug interactions. It could be sepsis, maybe meningitis, maybe it's elder abuse and she's been beaten and that's why she has head trauma, etc., etc., etc. If, on the other hand, that question, I had gone to the bottom line and the question was, what is the most likely antibiotic to treat this patient with? Right away, I know this change in mental status is sepsis, and I just have to look for a source of infection from the history and the physical. So right away, I'm not worried about subdural hematoma. I'm not worried about elder abuse. I'm not worried about drug interaction. I'm not worried about oversedation. I'm not worried about dehydration. I'm not worried about hepatic encephalopathy, uremic encephalopathy, DKA, non-ketotic hyperosmolar coma, all things that a patient can come in with from the nursing home. And I wouldn't know which one is most common just by reading the first sentence or two, obviously. I read that the patient needs an antibiotic. All I do is focus now what the patient's complaints are, vis-a-vis a possible infection. All right? So if they give me 15 medications, I don't have to stop at each drug and say, okay, I remember reading that drug maybe causes some mental status changes. And then you have 15 different drugs, and you're trying to combine every drug with every other drug to see if there's a drug-drug interaction. All right, then you look through all the laboratory tests and see, well, if the glucose is 150, is that high enough to have non-ketotic hyperosmolar coma? I don't think so. Is it DKA? I don't think so, etc., etc. And you might get the perfect answer to that question, have reasoned it brilliantly, but now an hour and 45 minutes has gone by and you're still on question number one. So it's essential you read the last line. Now, some people have come up to me and said, you know what, I went through the test, I got a 92, and all I did was read the first line and the last line. I barely read anything in the middle. I don't advise that. You need the information. You can't speed read through the test, but this method will help you focus. All right? So now, with that in mind, what I'll do is read the first line or two of the question, and then, and it's not going to be in your handout, I'm going to give you a question as if this was on the exam. And I'll give you some choices. And now, as you go through the case, you'll be able to think about what is important and what is not. So let's start with this first case. Chief complaint is my belly is swollen and it hurts. All right? That doesn't tell me very much. The differential diagnosis there is enormous. A 48-year-old woman comes to the emergency department with fever, abdominal pain, and abdominal distension. Okay? And I'm going to scan down to the last line. Now, this isn't in the handout. This is a way, again, to train you to look through these questions. And I'll tell you that the question reads, which blood tests are most consistent with this patient's clinical picture? All right? That alone doesn't tell you anything. They say it's amylase, lipase type question, there might be pancreatitis. If on the other hand, I then tell you that the 5 choices are all choices that have transaminases in them. Okay, so now right away you know this is somehow this abdominal distension, fever and pain is going to be related to what kind of problem? Liver disease, obviously. And let's say I give you choices such as okay? Now, when I read through the choices, I'm not going to stop and think about each one. I don't have enough information. I'm going to waste valuable seconds. And if in each question I'm wasting seconds, at the end of the test I've wasted hours. Okay? So I just know this is going to be a case where I know the woman who has fever, abdominal pain, and distension is going to have some kind of liver disease. So that's what I'm thinking about now. This is not going to be a question about what's a differential diagnosis of all the things that can cause abdominal distension. This is not going to be a question about a perforation. Fever, abdominal distension, maybe she perforated. This is not going to be a abdominal distension from a cancer, etc., etc., etc. Okay? So this exercise, I think, will be very useful. And as you do any practice questions, I would strongly advise you to use this method. Okay? In the last several months, let's go back to the case, she has developed ascites, anorexia, and progressive wasting. She also complains of severe itching. She's on no medications. She's a former intravenous drug user who has been discharged several months ago from an alcohol detoxification unit. She's a disheveled appearing woman, cachectic with grossly distended abdomen. Her temperature is 38.3, blood pressure is 110/70, pulse is 107, respirations are 22. Physical exam shows poor dentition, parotid gland enlargement, scleral icterus, her lungs are clear, and her heart has a regular rate and rhythm. Her abdomen is distended, tympanic, tender, and with shifting dullness. Liver edge is not palpable, but the spleen is palpable 3 cm below the left costal margin. She has bilateral pulmonary erythema and asterixis, multiple spider angioma, and excoriations are present. Okay, now I got to look at this and figure out what transaminase pattern correlates to what kind of liver disease she has. Okay? And now as you're reading through the question, let's go through and see what points you think are worth thinking about that will help you make a diagnosis. Very often, as you know, when you're going through a question, it's not just a matter of making the diagnosis. The exam will assume you've made the diagnosis, and they won't say, what is the diagnosis? Alcoholic hepatitis, cirrhosis, hepatoma. They won't ask you that, but they'll ask you something based upon the diagnosis you need to have made. You'll need to figure out step A to get to step B, which might be the question. So here, to answer this question, we obviously need to know what liver disease this patient has. So if I go through this question, she has fever, pain, and distension. I know she has liver disease. So right away, fever and distension, I think about what problem? In someone with liver disease? Infection. Infection, maybe she's distended from ascites. Okay? That would be the most likely scenario. She's developed ascites, so we're told that right away, anorexia and wasting. All consistent with liver disease, maybe cancer, but we're going to keep reading on. Severe itching, again, cholestasis from liver disease. No medication, so we can't blame any current medications. No hepatotoxicity. She's a former IV drug abuser. Okay, so right away, IV drug abuse, I say, okay. Several causes for chronic liver disease from intravenous drug use. What are those? Hep B and hepatitis B and hepatitis C. In either one of these, are we talking about an acute hepatitis B in this patient? Or an acute hepatitis C? Or chronic? Chronic. Acute hepatitis B, acute hepatitis C do not cause this kind of picture of end-stage liver disease or portal hypertension. Okay? Furthermore, you rarely see acute hepatitis C. When we're talking about hepatitis C, it's almost always chronic. Does hepatitis A cause this kind of picture of liver disease and probable portal hypertension? Never. Hepatitis A is never chronic. Okay? So it never causes cirrhosis. It's never associated with hepatoma. It never requires liver transplantation for chronic liver disease. On rare occasion, a fulminant case of hepatitis A may require liver transplantation acutely, but again, that's rare. Most hepatitis A presents either asymptomatic or mildly symptomatic, sometimes with jaundice, sometimes without, often in the setting of a community outbreak, because how is hepatitis A transmitted? Fecal oral. Okay? How is hepatitis B transmitted? Parenterally, through blood. Okay, in the old days, blood transfusion. The question might mislead you and say 2 years ago she had a blood transfusion. All right? And we know we've been screening for hepatitis B in the blood banks since the mid-1970s. So we're not giving patients hepatitis B anymore. You should also know that we don't give patients hepatitis C anymore. If we do, it's very rare because we know how to screen for hepatitis C. When did we start learning how to screen for hepatitis C? Say the early 90s. So again, if the question tells you someone got a blood transfusion and now it's hepatitis several months later or even several years later, if the transfusion is current within the last few years, it's not hepatitis B, it's not hepatitis C. All right? Most cases of hepatitis C in this country at the given moment are from transfusions years ago, and the other place people are getting it through needles is through intravenous drug use. Okay? So A, fecal oral, B, parenterally, injections, blood banks, and sexual transmission. Okay? So hepatitis B is easily transmitted sexually. Hepatitis C is rarely acute, almost always presents as chronic hepatitis, and transmitted chiefly by blood, meaning intravenous needles in drug users, or transfusions, say, before the 1990s. Okay? Hepatitis C is not well transmitted sexually. It's only maybe 5 or 10% tops that sexual partners over many years will develop hepatitis C. So B is blood and sexual transmission. C is almost always blood. Okay? And A is fecal oral. So, can she have acute hepatitis to explain this picture? No, because she has all these findings of chronic liver disease. Can she have chronic hepatitis B? Yes. Can she have chronic hepatitis C? Yes, okay. So, let's go on. She also has a history of alcoholism. She was discharged from an alcohol detox unit. So maybe she has alcoholic cirrhosis. Okay? Can this be alcoholic hepatitis? Yes, the stages in alcoholic liver disease are from steatosis, which just means fatty liver, where the patient might have mild elevation of the transaminases, to alcoholic hepatitis. We'll talk about that in a few minutes. And lastly, cirrhosis. These patients are almost always asymptomatic, just have mild LFT abnormalities. Alcoholic hepatitis will present acutely with fevers, maybe jaundice, transaminase elevations, right upper quadrant tenderness, maybe jaundice, an acute hepatitis picture. And cirrhosis can present, obviously, with all the manifestations of end-stage liver disease, which you're familiar with. Okay? So now, what are my leading possibilities? Chronic hep B, chronic C, and ETOH-induced cirrhosis. Okay? So already I've narrowed the list down to 3. She's disheveled, cachectic with a grossly distended abdomen, so again, she's quite advanced. Temperature is 101, she's tachycardic, a little tachypneic, and she has many signs and symptoms of chronic liver disease. Parotid gland enlargement, scleral icterus does not mean chronic, but in her case, it could be acute on top of chronic. Bilateral pulmonary erythema, and as we'll get to, asterixis. All right? What does asterixis imply? Some element of hepatic encephalopathy. Does it give us any clue in terms of the differential diagnosis? No. Just means the patient has portal hypertension and has asterixis, hepatic encephalopathy. Multiple spider angiomata and excoriations are present. Now, which of these pictures of transaminases are consistent with one of these? Now, do I have any way from the question of knowing whether she's hep B, hep C, or alcohol? No. So let's go through these questions. 2100, 3400. Does that look like a chronic hepatitis picture? of either viral hepatitis or alcohol? No. This is a picture you see with an acute hepatitis. Whether it's a viral, A or B, causes acute. C almost never causes acute. You won't see an acute hepatitis C on the boards. So this could be an acute hep A or hep B, but again, acute, not chronic. These transaminases, you should know the range of normal blood values of the common blood test, so you're not constantly flipping to the section where they have normal values. Transaminases normal is about 40 to 50. So these transaminases are normal. Can a patient with cirrhosis, end-stage cirrhosis, have normal transaminases? Yes. Okay? So that's a possibility. AST, ALT, 155 and 75. What does that pattern automatically imply? Alcoholic hepatitis. Okay? The AST is usually in the low hundreds and is almost twice or just around twice to 3 times the ALT. So this looks like an alcoholic hepatitis. Can our patient have an acute alcoholic hepatitis on top of her chronic hepatitis and cirrhosis, chronic cirrhosis? Sure. So that's definitely a possibility. 420 and 890. What does that look like? Well, it looks like maybe some other form of hepatitis. Viral hepatitis can give this. Viral hepatitis acutely usually gets much higher. So this doesn't really fit very well. So far I have either a cirrhotic liver or a patient with a cirrhotic liver and acute alcoholic hepatitis. And here, 12 and 400, that's not really a pattern that makes much sense. Usually if something's as high as 400, the other transaminase is also elevated. Okay? Now, it's hard to decide in this particular question. I deliberately made it tough to decide between a cirrhosis patient and an alcoholic hepatitis on top of cirrhosis. Okay? If I had to choose between these two, in light of the fever, the acute decompensation, it sounds to me like maybe she has something acute. So I would lean towards this, alcoholic hepatitis on top of cirrhosis. Okay? And I deliberately made it difficult to choose between these two to make you think. But on the boards, it will be much clearer. All right, there'll be more evidence of an acute hepatitis. There'll be more right upper quadrant tenderness. They'll tell you that there is some acute decompensation. All right, but again, this is an exercise again to deliberately make you think about each possibility in the differential diagnosis. Now, so the differential diagnosis we discussed. We'll go back to the handout: alcoholic cirrhosis and hepatitis, chronic viral hepatitis or acute hepatitis on top of chronic liver disease, which is what we think our patient has. Then this patient may have, in addition, some complications that are associated with chronic liver disease, such as spontaneous bacterial peritonitis, and maybe that's what's going on in this patient. Maybe that's why she now has the fever. Hepatoma, which does not present acutely like this, but is something we need to think about in any patient with chronic hepatitis and cirrhosis, is that the patient develops a hepatoma, hepatocellular carcinoma, on top of their underlying liver disease. Peritoneal carcinomatosis, yeah, that's possible. Maybe that's why she's distended. Maybe that's why she's wasted. But then again, I don't have anything else here to suggest a metastatic cancer. And I have a lot to suggest the fact that she has liver disease. And lastly, tuberculous ascites. Do I have anything here in terms of exposure? No. Does she have any risk factors for TB, though? Yes, alcoholics and drug abusers tend to have a higher incidence of tuberculosis. But again, does this sound more like a tuberculosis case that's widely disseminated or something that's acute on top of chronic liver disease? Obviously acute on top of chronic liver disease. Okay, as we go through these handouts, what I'd like you to also do is, as we go through the diagnostic plan and the results of those, I want to go step by step and not just rattle off a bunch of them. So what I would do is, if you're reading along with me, just go down the initial diagnostic plan and cover up line by line, and I'll give you the answers of what those are. Okay? So you're not confused by a big rush of data here. So you get a CBC and a peripheral smear. What would you expect in a cirrhotic to see on their blood count and a peripheral smear? Anyone with liver disease of any sort, this is not specific just for alcoholic cirrhosis or viral-induced cirrhosis. Any form of chronic liver disease will have similar effects on the blood count. So if we're talking about the white blood cell count, the hemoglobin and hematocrit, and the platelet count, how are these affected? Well, what's the factor that affects all the blood cells? Patients with a shrunken cirrhotic liver and portal hypertension will develop a big spleen. And they have splenomegaly and hypersplenism, where the spleen acts as a mega filter and filters blood cells. So the white blood cell count might be a little low. The H&H might be low, not only because of sequestration in the liver, but because the patient is bleeding, okay, or the patient has nutritional deficiencies, okay, such as folate in particular. And the platelet count, what will that tend to be? Again, low, because of hypersplenism. Okay? So these values, and I'll make up the numbers, let's say about 4,800, and our patient has a hemoglobin of 11 and a platelet count of 120. We're also told that the MCV is 100. Now, what does that tell us? Well, obviously that's high. What's the differential diagnosis of a high MCV in an anemic cirrhotic? Let's think about it. Well, any patient with end-stage liver disease tends to have higher MCVs, even in the absence of a nutritional deficiency like folate deficiency. All right? Alcoholics very often don't eat well, and therefore they get most of their calories from their alcohol. They don't eat fresh fruits and vegetables. That's not usually on their grocery list when they go shopping for tequila. And so their MCV might rise higher because of a folate deficiency. And you can get folate deficient within several weeks or a couple of months. If you're not eating B12, you will also become B12 deficient, but our stores of B12 can last us for several years. So when we're talking about a nutritional deficiency in an alcoholic, think about folate. Okay? But even in the absence of folate deficiency, all right, let's say this patient is eating plenty of folate every day. This patient can have an MCV purely from their liver disease. And lastly, we're told the patient on peripheral smear has acanthocytes, which are spiky-looking red cells. It's a little bit of an exaggeration. Again, not specific for any particular kind of liver disease, but present in patients with end-stage liver disease. All right, the next thing that happens is the patient has an elevated BUN and creatinine. Why do you think that is? Well, she's septic, maybe she's vasodilated, maybe she's sick, she's not drinking enough, and all this BUN and creatinine tells me is that she's pre-renal. All right, and in a little while we'll talk about the problem is of a patient with end-stage liver disease who becomes too pre-renal or too volume depleted. And you could develop something known as the hepatorenal syndrome. But this just shows me at this point that the patient has diminished flow to the kidneys. The ProTime is elevated, and the PTT is elevated. Why is that? Because a patient with liver disease does not have a liver that's doing what the liver should be doing. The liver detoxifies all kinds of poisons, and when you don't, you end up with encephalopathy. And it also makes a lot of proteins that we need, meaning our blood clotting factors. Which blood clotting factors are produced in the liver? All but factor VIII and von Willebrand factor, which are produced in the vascular endothelium. Which of those factors in the liver is dependent upon vitamin K? 2, 7, 9, and 10. All right? 2, 7, 9, 10 are vitamin K dependent. Yes, they are all made in the liver, but everything else is also made in the liver except for factor VIII and von Willebrand factor. Okay, now we're told that the AST and ALT, in this particular case, slightly different than I gave you, is let's say 200 and 100. Again, consistent with alcoholic hepatitis. And the patient's total bilirubin is 3.4. That's elevated. Alkaline phosphatase is normal. Albumin is low. Why is the albumin low? Because, again, chronic liver disease, you don't make albumin, and you will become hypoalbuminemic. And you see that the total protein is in the normal range, even though the albumin is low. Okay, so into reviewing this case, our patient clearly has evidence of chronic liver disease and portal hypertension. Doesn't tell us what the acute problem is. If I asked you a question based upon that case we just read, and I didn't give you this question, but I would ask you, what is the next step in the evaluation of this patient's liver disease? Okay, let's say that was the question. So right away, again, if you read the question after the first sentence, you know that this is a liver disease question, and I'm not going to entertain all kinds of other diagnoses for fever and abdominal distension. Let's say I told you the choices were abdominal CT, pelvic, sono, paracentesis, viral serologies, and liver biopsy. All right, in this particular patient, if the question is worded, what is the next step in the evaluation or management of this patient, which of these would you say? The patient's presenting into the emergency room with the case we just described. Okay, paracentesis. Why? Because maybe her decompensation, maybe her fever is due to spontaneous bacterial peritonitis, which occurs in patients with cirrhosis, okay, particularly alcoholic cirrhosis, and that is the cause of her decompensation. Can I make the diagnosis of SBP, spontaneous bacterial peritonitis, quickly after paracentesis? Or do I have to wait days to get a culture back? Make the diagnosis in 5 minutes. Stick a needle in, get the fluid out, and what do I need to do on that fluid? What's the first thing I do with that fluid? Not even a gram stain, because you need lots and lots of bugs to show up on a gram stain. But I have even a more sensitive way. Cell count. If I do a cell count, take a drop of that fluid, put it in a hemocytometer, or send it to the lab, and the lab tells me, yes, you have 580 polys and 200 lymphocytes. Have I made a diagnosis? Yes, because over 250 polys, PMNs, polymorphonucleosides, is the diagnosis of SBP. You don't have to wait for your culture to come back 48 hours later. If the paracentesis reveals a very low poly count, let's say 10, then you don't have evidence of an SBP. The patient probably doesn't have an SBP. I would still send that fluid for culture. But again, over 250 polys, you got a diagnosis of SBP. You draw some fluid to send for cultures. You draw some blood cultures. You start the patient on antibiotics. What is the most likely organism or group of organisms? Basically, think about where the ascites is. It's right around the bowel. Okay, and for reasons that are not unclear, bowel flora translocates into the ascites. So you have gram-negative enteric type organisms. All right. So if you got a choice of Staph aureus, Streptococcus, Candida albicans, E. coli, and make up choice number 5. Bacteroides fragilis. All right. Well, actually, that's an anaerobe, but I would still say E. coli are more common. So E. coli, gram-negative enteric organism. But I don't have that organism ID'd for a couple of days. So what do I need to do in terms of antibiotics? I choose typically a broad spectrum antibiotic with good gram-negative enteric coverage. Cefotaxime as a single drug is very good. Anytime you see an aminoglycoside as a choice, it is almost always the wrong choice, because we have very good gram-negative antibiotics, and we almost never want to use gentamicin. Certainly in a liver disease patient, gentamicin or tobramycin, any of the aminoglycosides will always be the wrong answer in a patient with liver disease, because they're more prone to the nephrotoxicity. So this is a very good drug to start the patient on while I'm waiting for my cultures to come back. Now, why are these reasonably intelligent choices that the test makers would choose to put in as distractors or the wrong answers? Abdominal CAT scan, is that a reasonable test to do? Sure, I'll see the shrunken liver, I'll make sure the patient doesn't have a hepatoma, I'll see the splenomegaly. If the patient has a intra-abdominal cancer and has peritoneal carcinomatosis, I'll see that. If I told you that this was an abdominal and pelvic CAT scan, that would also allow me to look at what organ that can produce massive ascites in a woman this age. Ovarian cancer. So pelvic sono would be a good choice too. So abdominal CAT scan, it makes sense why I might think about it. Pelvic sono, it makes sense. Viral serologies, sure, I want to know if the patient has acute hepatitis B or acute hepatitis C, again, doesn't occur. But if I want to look for the etiology of this patient's liver disease, I might think to do a hepatitis B serology. Which serology would I look for in a patient with chronic hepatitis B? If you choose one blood test to tell you that a patient has hepatitis B as the cause of their chronic liver disease, what test would you ask for? Right. HB surface antigen. All right. This means ongoing infection. This alone doesn't tell you if it's acute or chronic. This tells you that there's active hepatitis B in this patient. Okay? Surface antibody would tell you that the patient is immune to hepatitis B. Okay? So this is a reasonable choice in the evaluation of this patient's liver disease. Is it the next step in management after I greet the patient to the emergency room? No. Liver biopsy? Yeah, that's a gold standard for a lot of liver disease diagnoses. Am I going to do it as the first step in a patient who already has a cirrhotic liver? Will I find any disease that's liver disease that's reversible at this stage? No. So in general, if you have a patient with advanced liver disease and portal hypertension and cirrhosis, you don't need to do a liver biopsy. It almost always will be the wrong answer, because there's really no disease in the liver that can be effectively treated once you have all the signs and symptoms of end-stage cirrhosis and portal hypertension. Okay, and again, this patient has a coagulopathy, making it particularly dangerous. So here, this question, again, would have told you you're looking for a patient that has liver disease. What's caused their decompensation? Probably SBP. Okay? And I could make a series of questions, give you the same case and say, what antibiotic should this patient be placed on? All right, that would be the question. You get this history, has ascites, tender abdomen, fever. Even without getting the paracentesis, all they say is which antibiotic. And they tell you things like gentamicin, vancomycin, rifampin, because you're thinking maybe peritoneal TB, which is not very relevant, cefotaxime, etc. You know it's going to be cefotaxime. Okay? The question was, what's the most likely organism causing this patient's fever and sepsis picture? Again, E. coli would be the right choice. Okay? If they said a paracentesis is done, which of the following is most consistent with SBP? Poly count of 250. They ask you, this SBP is suspected, you do a paracentesis. What's the next step in evaluation of the fluid? Cell count. Okay? So you had a whole series of questions that can be asked based upon this fairly common end-stage liver disease picture. Okay. By the time we have ascites, we generally have advanced liver disease. And again, this patient had a lot of evidence for alcoholism or hepatitis B or C. But what other liver diseases can she have? Well, she's a middle-aged woman, and she has pruritus. So I'm at least going to think about the diagnosis of what liver disease hits women in their middle ages and presents with itching and elevated alkaline phosphatase, which our patient doesn't have, primary biliary cirrhosis. Okay, there I will check a certain antibody called anti-mitochondrial antibody for PBC, and I'll confirm the diagnosis with a liver biopsy. In this patient, if I suspected PBC, is it important to do a liver biopsy? No, the patient has end-stage liver disease. At this point, regardless of what this patient has as their underlying disease, I'm going to think about a liver transplant. Okay? Certain diseases do better with liver transplants than others. PBC, primary biliary cirrhosis, happens to do very well with liver transplant because it's rare for the PBC to recur in the new liver. Do we transplant patients with end-stage liver disease with hepatitis B? Yes, but we think very hard about ways to prevent hepatitis B from recurring. And there's a number of different antiviral protocols to give the patient who has a history of hep B, because recurrent hep B in the new liver is fairly common. Similarly with hepatitis C, we will transplant the patient, even though we know a large number of those patients will develop recurrent hep C in the new liver. But PBC rarely recurs, and it's an excellent indication for a liver transplantation. Okay. There are other more rare genetic diseases that we talk about in the discussion here, like Wilson's disease. Does Wilson's disease present in a woman who's 48 with liver disease? No. It's a disease that presents much younger, typically teens, 20s, maybe the 30s. First with neuropsychiatric disturbances and then the liver disease. This patient has no history of neuropsychiatric disturbances. She wouldn't have gone to 48 before she developed her liver disease. Alpha-1 antitrypsin disease. And what's the lesion in Wilson's disease? Excess copper deposition. All right? So we'll do a serum copper and a serum ceruloplasmin, and those will be abnormal as screening tests. For Wilson's disease, what will I look for on physical examination? I'll ask to do a slit lamp examination to look for the Kaiser-Fleischer rings in the eye. That's pathognomonic. All right? And the gold standard for Wilson's disease? Liver biopsy. Again, there's no evidence here this patient has Wilson's disease. How about alpha-1 antitrypsin disease? I can measure the alpha-1 antitrypsin level in the patient's bloodstream. I can measure the patient's genotype. Okay? And I will take a family history, because what other organ besides the liver is involved in patients with alpha-1 antitrypsin, the lung. And they get emphysema even if they're not smokers. So if this question told me that this patient didn't have a history of drinking, didn't have a history of IV drug use, had a brother that died of emphysema at 25 who wasn't a smoker, and her mother died of liver disease in her 20s, I would say, gee, that makes me think lung, liver, early, no other risk factors for liver disease, think alpha-1 antitrypsin. The gold standard to diagnose alpha-1 antitrypsin, again, liver biopsy. Okay, there's no drugs on this patient's list to make me think of chronic liver disease, and in fact, usually, chronic liver disease does not result from hepatotoxicity from drugs, because usually the patient presents with an acute picture of LFT abnormalities and the drug is stopped. Which drugs? INH is one you need to be aware of, alpha-methyl dopa, an old hypertensive, methotrexate, which is used for rheumatoid arthritis, and can be used chronically. So at least I'll think about in a patient with rheumatoid arthritis and methotrexate, if there's liver function test abnormalities, I want to think about methotrexate. And the most common one is acetaminophen for liver disease. But again, is acetaminophen liver disease acute or chronic? Almost always acute. And they'll present with a acute hepatitis picture with transaminases often very high. What other substance in combination with acetaminophen greatly increases the risk of hepatotoxicity? Alcohol. And even a relatively small amount of alcohol and a relatively small amount of acetaminophen can give you a very sick patient with really fulminant toxic hepatitis. And that could be a question. Someone goes out drinking one night, they have a hangover in the morning, they take some acetaminophen, and by the end of the day they're feeling very weak, they're confused, they're lethargic, they're not still drunk, they're not a chronic alcoholic, so you don't need a big differential for change in mental status. What they want you to think about, they say the word acetaminophen, and they say the word alcohol. That's when this far within each other on the page, it's going to be a combined acetaminophen alcohol toxicity patient. Okay, so remember that combination. Okay. One last point I want to make about this patient's ascites in particular is the concept of determining if a patient's ascites is due to their portal hypertension. And there's a simple test that we do. That's called the serum ascites, or serum ascites albumin gradient. Meaning, the question has to give me certain information. They have to tell me the patient's albumin in the serum, which in this case was 2.8. They have to tell me that when I did the paracentesis, how much albumin was in the fluid. And let's say in here I tell you it's 0.8. And then to figure out this complex formula, the SAAG, the serum ascites albumin gradient, I just subtract 0.8 from 2.8. This gradient, meaning the difference, all right, we had to make it sound fancy. Gradient, just a subtraction. 2.0 indicates portal hypertension as a cause of the ascites. Anything greater than 1.1 tells you that the cause of the ascites is portal hypertension. Anything less than 1.1 suggests something else. Congestive heart failure with fluid overload. Okay? Peritoneal carcinomatosis. Tuberculous peritonitis causing ascites. Okay? Here, there is a larger difference between serum albumin and acidic albumin. Okay? So, the question, how can the question appear? They'll tell you which of the, they'll give you a serum albumin, they'll give you an ascites albumin, and a clinical history, maybe like this picture, but they'll make it a little more confusing. The patient works in a homeless shelter, or the patient is an alcoholic who lives in a homeless shelter, and she had a strong family history for breast and ovarian cancer. So now I'm thinking, oh man, TB, homeless shelter, alcoholic, family history of ovarian and breast cancer, maybe it's a familial syndrome and she has ovarian cancer, and there's no way to know. But you can figure out the gradient. And if the gradient in this case is 2, you know it's going to be from portal hypertension. In an alcoholic, I'm going to assume it's alcoholic cirrhosis. Okay? So this can be a question very simple to calculate and help distinguish. The higher the gradient, think of this easy. The higher the gradient, hypertension. The higher the pressure in the portal system. Okay? All right. Okay, now we've gone through most of the remainder of the further diagnostic plan, further diagnostic testing. On the following page, we've again discussed all of this already, and the treatment plans. So we have a patient with ascites. Well, first of all, if the patient had SBP, we're going to put the patient on antibiotics. How do we treat ascites? Well, first we're going to limit the patient's salt and water intake. Okay, that reduces the amount of fluid. We're obviously going to tell them to stop drinking, because if you stop drinking, you'll have less progression, even if you already have cirrhosis. We're going to tell them, because you're cirrhotic, we want to make sure you have adequate nutrition, so you have to eat protein, but try not to eat animal proteins, because their metabolites lead to hepatic encephalopathy. All right, so we'll tell them no fat, no red meat that's high animal fat, high animal protein, because those amino acids that are metabolized from the protein can produce encephalopathy. So we want non-meat sources of protein. Theoretically, if you have food that is enriched in branched-chain amino acids, that might protect against encephalopathy. There's a theory that aromatic amino acids cause encephalopathy, whereas branched-chain amino acids might help protect against them. That's not going to be a question, though, on the boards. They'll have more general questions like what kind of dietary restriction, salt and water restriction. Okay? What are the triggers for patient to develop encephalopathy? We're going to leave that for one of the upcoming questions. A 72-year-old man comes into the emergency room vomiting blood. Let's skip down to what the question is, and let's say I tell you the question is, what is the next step in evaluation of this patient? Place an intravenous catheter, check a serum ethanol level, do an EKG, do an endoscopy, put oxygen on via tight-fitting face mask. So right away, I know this is a straightforward GI bleeding management question, all right? So, the patient has a known history of ethanol abuse and has had a couple of episodes of upper GI bleeding in the past. He was on a drinking binge early today, and 1 hour ago was found by the emergency workers in a pool of blood on the sidewalk. He denies any pain at this time. Okay, so from those choices I gave you, let's rattle them off. Put an intravenous catheter, check a serum ethanol level, EKG, endoscopy, or O2. Which one? IV. All right. If you're doing this as a CCS question, the first thing you would do would be put an IV in. Okay. If you say put oxygen on, do an EKG, you're going to start losing some points. All right. First thing is the patient can exsanguinate, can bleed out if you don't have access. Okay. You could be real smart and figure out exactly what the patient has, but if the patient's bleeding and you can't put fluid and blood, the patient's going to die of exsanguination. Okay? So that's what you got to prevent. Let's say I give you a follow-up question. This is step 3. You guys need to know which lines to put in. And the question is what kind of intravenous access would you provide? And let's say the choices are a 24-gauge angiocath in the dorsal vein of the hand, a intravenous catheter in the femoral vein. Is that considered a central line? It's considered central circulation, big line, right? How about a brachial artery catheter? Well, that's a really big line. But do I want to infuse anything into the artery? No. Okay. Swan-Ganz catheter, pulmonary artery catheter. Yes, that's a central line, but again, there's a lot of risks with a pulmonary artery catheter. Or two peripheral 16-gauge IVs in each patient, in each arm. All right. Now, at this level, you should know about the different size IVs. Pediatricians will use in their little kids 24 gauge. The smaller the number of gauge, the bigger the catheter or the bigger the needle. Right? So in a baby, 24, maybe even a 26 gauge, little butterfly needle. In adults, a small line, let's say you just want an intravenous line to put in antibiotics, not in this patient. A 20 gauge catheter is fine. Remember, the bigger the catheter also is the bigger the pain and the bigger the hole you're making in the vein. So I'll use the catheter that will cause the patient the least pain that will be sufficient for my purposes. So 20 gauge catheter is okay for routine intravenous medications. If I have someone's bleeding, I want a bigger line, 18 or 16. All right? They won't ask you to pick between a 18 and a 16 or between a 16 and a 14. All right? If you're an internist or a gastroenterologist, we're sort of weak and delicate. We'll put in a 18 gauge maybe. Whereas if you have a surgical resident in the emergency room, they'll put in a 2 gauge, which is about the size of my head, all right? Because they're aggressive and they're macho, okay? But basically, it doesn't matter what your name tag says, whether it says internist or chief surgeon, you need peripheral access. Now, a femoral vein is a big vein, all right? You get a lot of fluids in there. What's the problem with femoral vein? It's dirty down there, all right? It's a site that's hard to keep sterile. All right. Now, do we sometimes put them in? Yeah, let's say the patient's very volume depleted. This patient might be exsanguinating. Maybe a few hours ago, the patient had the biggest veins you ever saw, but now there's no blood in those veins. So you got to dig deep for a big vein. Putting a line in the femoral vein is not a terrible choice in that situation. All right. Because if you put in a central vein catheter, what's the safest place to do it in terms of the actual puncture? The groin, all right? It's very hard to cause a pneumothorax putting a needle in here, all right? No matter how inexperienced you are, you got to really work very hard with a very long needle to puncture a lung going in here, all right? You could hit the femoral artery here, okay? You could cause femoral artery dissection. You could cause infection in a femoral vein, all right? It's hard also to damage any important pelvic organs in the femoral vein, all right? So you're not worried about internal organ damage. So femoral vein is good for quick access to the big line, but if it's going to stay in any length of time, it's a hard area to keep sterile. Okay? So that's obviously not the best choice. Too large peripheral lines. Let's go back to the question. A patient is afebrile, tachycardic, BP very low. So this patient might be in hypovolemic shock from bleeding. So is this a small bleed or a big bleed? Big bleed. Patient is stuporous and reeks of alcohol, all right? Icteric, gynecomastia, and spider-angiomata. As I'm reading through the question, what does that tell me? Is this patient having their first episode of liver problems? No. Gynecomastia occurs in men with chronic liver disease, and they have a number of secondary sexual characteristics that appear because the overproduction of conversion of androgens towards estrogen. So they have gynecomastia, they could have testicular atrophy, all right? And these are things, again, that tell you chronic liver disease. Spider-angiomata, again, chronic liver disease. Tachycardic, lungs are clear. Even, do I worry about a lung exam? If this was a CCS question, would I get points or lose points for a patient like this listening to the lungs? Any stuporous patient who comes in is at risk for aspiration, all right? So listening to the lungs is never a bad idea in someone who's an alcoholic, especially if they're decompensating, they're shocky, maybe the patient's exsanguinating, and has an aspiration pneumonia. So again, it's not the first thing I want to do, but it's something to think about. Abdomen is soft, non-tender, non-distended. Patient has obvious splenomegaly, significant rectal exam for melena, no masses. So what's our differential diagnosis here? Can you tell me with ultimate confidence whether this is a esophageal variceal bleed or a massive gastric ulcer bleed? Could you tell me for sure what this patient has? No. All right? But I'm going to worry about both of those, but what's the one that is probably more likely to be asked about? Varices, because it's related to the portal hypertension. In fact, if you take alcoholics with varices, with known varices, and the patient comes in with melena, about half the time the bleeding is somewhere other than the varices. Remember, they're drinking, maybe they have gastritis, maybe they have ulcers, etc. Okay? So remember, just because a patient has known varices even, doesn't mean they're bleeding from varices. Does it matter at this particular moment if the patient is bleeding from varices or gastric ulcer? Well, the first step, putting in an IV catheter, no, it doesn't matter. Okay, or 2 IV catheters, sending a type and cross, doing all the usual things for an upper GI bleed, it doesn't matter. When it does matter is because we have a specific medication that we will treat bleeders from varices that we only use for variceal bleeders. We don't use it for gastric ulcer, all right? And that medication is called octreotide, okay, which is the analog for somatostatin, okay? So yes, it makes a difference. But again, before we do a certain diagnostic procedure, we don't know. So first thing we do is stabilize the patient, send the patient off, the bloods off for CBC, for platelet count, for ProTime, again, all things that might be abnormal and impact on our therapy. And then I'm going to do the definitive diagnostic test, which for an upper GI bleed is always upper GI endoscopy. Okay? At that time, the gastroenterologist will tell me exactly where the bleeding is coming from. All right? How long does it take to mobilize a gastroenterologist to do an upper endoscopy? It doesn't take days. It shouldn't take more than theoretically an hour. So the gastroenterologist gets out of bed or comes from the office or comes from upstairs, puts the scope in, etc. That should happen within an hour, not hours. So if you're thinking in terms of CCS, computer case simulation time frames, put that early. All right? Don't pick hepatitis serologies. Don't do serum ethanol levels. That's not pertinent. All right? You'll have the endoscopy done quickly. Okay? So you do the endoscopy. Well, we'll get to that in a minute. Okay? So let's talk about the differential diagnosis. Bleeding varices is one possibility. Mallory-Weiss tear. What's that? It is a laceration where in the esophagus? Where in the esophagus? At the esophagogastric junction. What is the typical history that you might hear? Not always, but usually. Vomiting first, non-bloody material, followed by continued retching or vomiting, followed by bright red blood vomitus. Okay? Because it's a tear. It's not a perforation. All right? It's not Burhoff syndrome where you perforate through the full thickness of the wall. Excuse me. It's a laceration of the mucosa. An endoscopy will make the diagnosis definitively. And the endoscopist can also stop the bleeding of a Mallory-Weiss tear, as he or she can do with many causes of upper GI bleeding, directly through the endoscope. Okay, so let's just get down to differential. We said varices is certainly a possibility, and the most common places those occur, the esophagus. Patient, we don't have a history of vomiting in this patient, but could it be a Mallory-Weiss tear? Sure. Can it be related to peptic ulcer disease? Say a gastric ulcer or a duodenal ulcer? Yeah, sure. Could it be gastritis or duodenitis? Does alcohol cause gastritis? Yes. Has the patient been taking NSAIDs, aspirin? I don't know, but certainly these would account for 99% of the bleeds you'll see on the boards, and in real life too, okay? And in the alcoholic, I'd say this is probably the one you're most likely to be tested on the boards. So, how do I distinguish between all these findings? I call my gastroenterologist, ask him or her to come down to the emergency room, bring the endoscopy machine with him, bring the endoscope, because if I have to, I'll scope the patient right in the emergency room because the patient's unstable, okay? And what will the endoscopist do? They'll put a scope in, and they'll see right away whether there are varices or not. What are varices? Varices are nothing more than veins, just like the veins in your hand. And when the pressure in those veins builds up, if you want to know a magic number, 12 millimeters of mercury. That's a step 1 type question. What is the absolute value of portal pressure that you need to have a variceal bleed? It's about 12 millimeters. We can't measure that clinically. All right, so I ain't going to be on step 3. But you see big varices and what we call stigmata of recent hemorrhage, meaning I could have veins that look just like this. Those don't look like they just bled. If on the other hand, I tell you these veins have red clots on them, or little white platelet fibrin plugs, little white plugs, or little red clots, or a red streak that looks like someone took a whip and whipped the varices. That's called the red whale sign. Those are all what we call stigmata of recent hemorrhage. I could be pretty certain that the patient bled from varices. Because if I look in, I see varices that look dry and small and I look in the stomach and there's a lot of gastritis, I don't know which one bled, but if there is no stigmata on the varices, I'll say, well, the patient probably bled from their gastritis. The endoscopist can also tell me if this patient has Mallory-Weiss tears, whether there's a gastric ulcer or duodenal ulcer, whether there's gastritis. And furthermore, the endoscopist can then stop the bleeding of varices. We could put rubber bands around them through the scope without even removing the scope. We call that esophageal variceal banding. Or the older technique, which is still used all the time, is sclerotherapy, where we take a needle, put it through the scope, and inject a sclerosant solution directly into those veins. Which is safer, if you ask to pick between the two? Banding. Because again, banding, there's no injecting into the varix. Remember, the varix is your circulation. And that needle is coming through the scope, which has gone through the mouth. That's not sterile. So we're taking a non-sterile object and injecting a sharp needle into a vein. So there's risk of infection there. So if you have a choice between esophageal variceal banding and sclerotherapy, pick the banding. Mallory-Weiss tear, the endoscopist, and they won't ask you which technique, but you should know the endoscopist can stop the bleeding, injecting it, cauterizing it, etc. Ulcer disease, again, the gastroenterologist can inject it, they can cauterize it, they can burn it. We have all different kinds of ways of stopping bleeding through a scope. And lastly, gastritis, which is a more diffuse process, we have difficulty stopping the bleeding because it's a diffuse process. There's not any single blood vessel that we can go and attack. Right? So an endoscopy is going to be the most important diagnostic test and therapeutic test in a patient with active GI bleeding. Okay, so let's go back to the syllabus. The initial management plan in the case of an upper GI bleed is the same for all causes. Focus on stabilizing the patient. IV catheters, give fluids. If you don't have a way to do the endoscopy right away, there's some rationale for doing a nasogastric tube. I would put nasogastric tube actually low down on the list because I know I'm going to endoscope this patient very shortly. I'll be able to suck out all the blood I need to through the scope. Get a CBC. I'm worried about maybe the patient's thrombocytopenic, and of course I want to know the patient's hematocrit. SMA 12, not immediately essential, okay, because it's not going to change anything I do right now. Okay, I'll find out the patient has a low albumin, etc., but it's not going to affect anything I need to do vis-a-vis stabilizing the patient. And obviously a ProTime and PTT is important because if there's a coagulopathy and the patient is actively bleeding, what else will I give the patient? If the patient, let's say, turns out this patient has a hematocrit of 19, hemoglobin of 6 grams, I'm probably going to get, not probably, I better give that patient what kind of transfusion? Whole blood, platelets, fresh frozen plasma, or red blood cells, packed red blood cells? Packed red blood cells. If I tell you the patient has an INR of 2.5 and a ProTime of 22 seconds, what do I give the patient? I give them packed red blood cells and fresh frozen plasma, okay? Which will correct the elevated INR and ProTime, okay? The original diagnostic plan shows that there's blood clots and coffee grounds when you do the initial lavage, which again is not essential, but there's no evidence of active bleeding. Hemoglobin is low, not as low as I told you. Platelet count is 80,000. Would we transfuse platelets at this level? Probably not. All right, if the patient had a platelet count of 10,000, yes, sure. But patients with cirrhosis and portal hypertension don't get platelet counts of 10,000 unless there's something else causing the thrombocytopenia. The thrombocytopenia seen from hypersplenism is rarely under 70 to 80,000. And most typically it's in the low 100 range. Okay? We're told the sodium is high. The BUN creatinine ratio, again, greater than 20 to 1. That greater than 20 to 1 BUN creatinine ratio, we'll talk about this when we talk about upper versus lower GI bleeds. When it's more than 20 to 1, it suggests an upper GI bleed. When we'll talk about lower GI bleeding, sometimes we even see a ratio of 40 to 1. That's really suggestive of an upper GI bleed. Okay? And we're told that the patient's jaundice, elevated AST and ALT. What do those AST and ALTs suggest? What liver disease? 240 and 80 suggests alcoholic liver disease. Alk Phos 160 and the ProTime and PTT are elevated. All as we would expect in a patient like this. Okay. Now, once the endoscopist has controlled the bleeding. Let's say this was a variceal bleed. The endoscopist puts on bands, controls the bleeding. What is the next step in management? Next step in management, every patient with a variceal bleed should be put on a octreotide infusion, okay, for the next 48 to 72 hours, because that reduces the risk of rebleeding. It's now standard protocol for a variceal bleeder. It has replaced vasopressin because octreotide is effective in lowering splanchnic circulation and therefore lowering portal pressures, and it does not have the important side effects that vasopressin has, which is peripheral vasoconstriction, meaning your fingers, your toes, small vessels. I don't really care if the patient has fingers and toes that are a little numb and a little tingly and a little blue. I'm worried if the coronary arteries get a little tingly and numb and blue. Okay? So I worry about coronary vasoconstriction from vasopressin. Octreotide has none of those side effects. Okay? Once the patient is stable, we have another drug that we will use to control portal pressures. Octreotide controls acute portal pressures. Decreases portal pressure acutely. Do I use the drug chronically? No, it's only IV, or actually sub-Q, and we never use it for controlling portal pressures chronically. What is the drug that lowers portal pressures chronically, long-term, and should be a maintenance medication in every patient with portal hypertension? Beta blockers, unless the patient has a contraindication to beta blockers. How much beta blocker? Well, first of all, would I give this patient a beta blocker with a blood pressure of 80? No. Patient has to stabilize. This is an oral drug, doesn't work within a few minutes anyway. So once the patient is stable, is taking a PO diet, because the patient is actively bleeding, I won't feed, then I will give the patient a beta blocker, and I'll titrate it to a heart rate of about 60. Okay, I'd like to see the patient basically maximally beta blocked to know that I'm doing the best I can to lower portal pressures. Okay, so that's the long-term plan in this patient. If the patient had had some of those other causes of bleeding, Mallory-Weiss tear, the gastroenterologist could stop the bleeding if it hasn't already stopped by injecting it. If it was erosive gastritis, well, then I'll think about what was this patient doing that led to gastritis. And what are the common causes? The most common cause. NSAIDs, or aspirin, and alcohol as well. Okay? And peptic ulcer bleeding, again, I'm going to have the gastroenterologist stop the bleeding if it's continuing to bleed, and then I'll start the patient on an anti-ulcer regimen, okay, which we'll talk about in one of the upcoming cases. Next case. A 58-year-old man is brought to the emergency room complaining of painless blood per rectum. And I tell you that the question then says, the most likely cause of blood loss in this man is from esophageal varices, diverticulitis. Let me write these on the board. So it's something to think about as we read through the question. Okay, so esophageal varices, diverticulitis, diverticulosis, colon polyp, or ulcerative colitis. Okay? Just looking at it, I probably know, even from the first sentence, I could probably eliminate several choices, but we'll get to that. Painless blood per rectum, he was doing well until yesterday, when after getting up from the toilet bowl, he noticed some maroon blood in the bowl. He felt a little lightheaded and sat down, and the symptoms passed. This morning he had a similar episode. So he's basically been bleeding for 24 hours. He denies any fever or current abdominal pain. Bowel habits have generally been otherwise normal. He denies hematemesis or history of ulcers weight loss, or cardiac disease. Okay? From this history alone, again, when I'm reading the question, I read the question to completion because I don't want to keep going back to the choices back and forth. I scan the choices before I start doing the question just to get an idea of what I'm going to look for. But right away, I can tell that several choices don't fit because this is an acute bleed in someone who's otherwise not bled and has not had any abnormal bowel movements. So can it be varices? Can it be? Possible. Can it be diverticulitis? No, diverticulitis is inflammation, pain, left lower quadrant tenderness, maybe some mild obstructive symptoms, fever, doesn't bleed. Could diverticulosis bleed like this? Yes, so that's a possibility. Colon polyp. Colon polyps usually present with maroon stool, big bleeds. Rarely. Most colon polyps are asymptomatic until they present with a cancer. So that's unlikely. Ulcerative colitis, acute onset with normal bowel movements previously? No. Colon polyp, probably not. So I'm down now between varices and diverticulosis already. Okay? He's a well-appearing man. He's orthostatic in that his pulse rises 20 points. His blood pressure goes down by about 20 points. Heart and lungs tachycardic. Abdomen unremarkable. Gross maroon clotted blood on rectal exam. So looking at this list, I have to choose between esophageal varices and diverticulosis. Do we have any history to suggest alcohol, liver disease, or any cause of liver disease? Nothing at all. All right? Nothing. Is there anything on the physical to suggest chronic liver disease and portal hypertension? Contrast this to all the other findings we had on our first couple of patients. Right? So no. So is esophageal varices, is it possible to bleed like this? Yes. Is it more likely in a patient without any history, without any stigmata on exam, to be more likely than diverticulosis? No. So I'm going to pick this as my answer. Because I know that lower GI bleeding, especially in the older patient, 58 is not that old, but let's say it was 68 or 78, certainly in those age groups, as well as 58, diverticulosis is the most common cause of bleeding. Okay? Another cause, again, remember this is an acute bleed, and this is also a bleed without associated bowel symptoms. So ulcerative colitis doesn't fit. How about ischemic colitis? Let's say that was a choice. When do we see, what kind of patient has ischemic colitis? Usually, but not always, patients who have other signs of atherosclerotic heart disease. Did we get any of that in this question? No. The other kind of patient who gets ischemic colitis is someone who's hypercoagulable. Any history here of hypercoagulable events? Being on oral contraceptives, which can make you hypercoagulable? No. So ischemic colitis is not likely. Can it present with bleeding for 24 hours? Ischemic colitis? Yes, it can. But usually there's some tenderness with it, there's some diarrhea with it, there's some fever perhaps with it. It's not usually just painless bleeding, ischemic colitis. Diverticulosis is nothing other than fresh bleed. Patient may have no history of diverticular symptoms in the past. I mean, think about it. Most people who have diverticuli never have symptoms from them. They're just a coincidental finding. So most patients with underlying diverticulosis don't even know they have it. And then they bleed. This is the most likely cause. Another cause for painless bleeding are arterial venous malformations. Usually in the elderly, almost always in the right side of the colon, often other signs of cardiac disease. And it is said, there's some debate, that it is more common in patients with aortic stenosis. Painless bleeding, painless bright red blood or maroon stools. Okay? What is the diagnostic test that we will do in this patient? Well, again, the standard things is to first stabilize the patient, all the things we already talked about for an upper GI bleed. I don't really think this patient has esophageal varices, so I won't do an upper endoscopy as my first step. If this was CCS and I ordered an upper endoscopy, I'd lose points if I did an examination of the upper GI tract before the lower GI tract. In the emergency room, right away I could put in an anoscope, which only goes in about this far, just shows me the anal canal. All that really does is exclude the possibility of a very big hemorrhoidal bleed. But do I think this patient with maroon stool has hemorrhoidal bleed? No. It's somewhere more proximal in the colon. So anoscopy is of no value. Flexible sigmoidoscopy, yeah, it's quick. It's easy. I can do it right there in the emergency room, and it'll tell me whether the patient does have something in the sigmoid colon or in the rectum. Okay? But do I get very far in the colon? No. So the most important diagnostic test in the patient with lower GI bleeding is colonoscopy. All right? Now, colonoscopy cannot be done as quickly as an upper GI endoscopy in many patients because the patient might not be well prepped. On the other hand, blood is a very effective laxative. Okay? So if you're bleeding, it usually cleans out everything in its way. So you could do a colonoscopy sometimes right away in these patients and see the entire colon. That will tell me whether there are diverticuli that are bleeding. That will tell me whether there are arteriovenous malformations in the right side of the colon. Okay? It'll obviously exclude things like polyps that are bleeding, ulcerative colitis, which I don't think this patient has, ischemic colitis. Colonoscopy can assess for all of those. So the single most important diagnostic test in a patient with lower GI bleeding is colonoscopy. Let's say the question gives you a scenario whereby colonoscopy doesn't find the source of bleeding. Let's say the whole colon is full of blood. Or the colon is just not well prepped and the gastroenterologist can't tell you where the bleeding is from. What is the next step in a patient who, let's say, has stopped bleeding and a colonoscopy has not been helpful? The next test, I would say, is a bleeding scan, a nuclear medicine bleeding scan. Why is that, and how is the test done? Well, what's done is the red blood cells of that patient are labeled. The patient has an injection where the labeled red blood cells now travel throughout the bloodstream. And that label lasts in the bloodstream for about 24 hours. So if the patient has stopped bleeding, it might be negative right now, that exam, and 6 hours from now I could send the patient back down for a repeat scan, and now I see where blood is leaking out of the GI tract. And so let's say I find that the colon, outside the colon on the bleeding scan, there's a little pool of blood here right near the cecum. What would that tell me? Well, the cecum is probably more likely to be AVMs and diverticulosis. So I would, again, think about how could I get there to stop the bleeding. So a bleeding scan is non-invasive. A bleeding scan is sensitive. It'll pick up even small amounts of active bleeding, but you need to have some active bleeding. Blood has to get out of the bloodstream to pool somewhere. And it gives us the advantage of we're able to repeat the scan if the patient stops bleeding and rebleeds. Let's say, on the other hand, the patient has a colonoscopy and it's active bleeding everywhere. Can't see a thing. There's just blood everywhere I look in the colon. What can I do then? Well, again, if the patient's bleeding very actively, and if they're hemodynamically unstable, do I want to send them to the nuclear medicine? Sit there for a few hours while they're being scanned? No. If the patient is bleeding actively and briskly and has significant blood loss and hemodynamic compromise, what I might want to do is an angiogram, which is more invasive, but also gives us the ability to stop bleeding during the angiogram by either injecting vasoconstrictors or some substance that the radiologist can put in to stop bleeding. All right, so the sequence is flexible after stabilizing the patient, flexible sigmoidoscopy because it's quick and dirty, you get it done right away, but it gives you very limited information. Then I want to do a colonoscopy because that will see the whole colon and can really evaluate for any colonic lesion. If the colonoscopy either can't be done because the patient's not prepped, or the colon is just full of blood and is actively bleeding, and the gastroenterologist can't tell me the source of blood loss, if the bleeding is very active, I'll go to an angiogram, because there I can actually do something to stop the bleeding. If the bleeding looks like it's already slowed down, a nuclear medicine scan is a better test. Which test can pick up lower or slower rates of GI bleeding? Nuclear medicine scan or an angiogram? Nuclear scan. Okay? And again, nuclear scan, non-invasive, allows you repeated testing over the next 24 hours. Now, let's talk about the management of diverticular bleeding. And this may show up on the boards in what looks like a surgical question, because there is surgical management we do in patients with diverticular bleeding. What is the natural history of diverticular bleeds? Usually in elderly, it can be either right-sided or left-sided bleeding, right-sided tics or left-sided tics. These are patients who have diverticulosis and not itis. Diverticulitis is an entirely different clinical picture. And what is the natural history? Most bleeds from diverticulitis stop on their own. Without having the gastroenterologist do anything, without having the interventional radiologist do anything, they stop. About 1/3 of them will re-bleed. And that's when we start thinking about whether we can either do something non-surgically or the patient's ready for the OR. Certainly, if the patient bleeds a second time and we scan the patient right away, or we colonoscope the patient right away after the second bleed, and we still don't know the exact source, then we might say, well, let's just sit tight and see where the bleeding is from. But if it's a massive second bleed, or the patient has a third bleed, certainly you're going to operate on that patient. Okay? So, again, diverticular bleed. Most stop, so it's going to be conservative management as the first step. Stabilize the patient, transfuse, do the workup we talked about, and then most patients will not re-bleed. So if the patient stops bleeding, you'll just observe the patient. If the patient re-bleeds and the bleeding stops again, that's more of a gray zone. Some people say, well, let's watch, see if it ever happens again. Some people say, well, let's say it was a big bleed twice within 24 hours. Those patients should probably go to the OR. So it's clear that if you had one bleed and you stop, you don't need surgery. It's clear that if you have a third bleed within a short period of time, within that first hospitalization, you need surgery. They won't ask you about 2 bleeds that stop. Okay? Everyone follow? First bleed, conservative management, because most patients don't re-bleed. The patient bleeds and stops, bleeds again, go to the OR. Do a resection of that area with diverticuli. Okay, again, it's painless and has nothing to do, diverticular bleeding has nothing to do with diverticulitis. Arteriovenous malformations, painless rectal bleeding, same presentation as diverticuli, could be in the same age group, older patients. Both patients, either diverticular bleed or an AVM bleed. Either patient can have cardiac disease. So the presence or absence of cardiac disease does not definitively help you distinguish between AVMs and diverticulosis. Don't be confused that just because a patient has an aortic stenosis murmur doesn't mean necessarily that the patient is bleeding from AVMs. The treatment is to make the diagnosis with colonoscopy and then treat it through the endoscope. We can inject it or cauterize to stop bleeding. Let's go through the other etiologies of lower GI bleeding. Colon cancer, colon polyps rarely present with bleeding. Most colon polyps are asymptomatic, all right, and they're found because we're doing a screening colonoscopy or we're doing a colonoscopy for other reasons. Most of them do not present with bleeding. Some may present with iron deficiency anemia if they're quite large. And as they grow larger, I'm more worried that they'll present with colon carcinoma. Colon carcinoma, colon cancer, almost always originates in colon polyps. And it does not usually present, colon cancer does not usually present with brisk bleeding. The most common presentation of a colon cancer is iron deficiency anemia and or some gradual, progressive, obstructive type symptoms. Okay? Colon cancer will never be on my list, number 1 on my list, for an acute lower GI bleed. Iron deficiency anemia in a patient in this age group, 60, 70, certainly is going to be the very top of my list. So that's chronic bleeding, slow bleeding, microscopic bleeding, think colon cancer until proven otherwise. An acute bleed, think of something other than colon cancer. Okay? Hemorrhoids can bleed. They can even bleed massively, but that's not common. The rectal bleeding from hemorrhoids is bright red blood. The question will tell you it's on the tissue paper when the patient cleans. It's in the water. Patient might think it's an enormous amount of blood because the water in this toilet fills up with blood. And it's very common for patients to get to overestimate how much bleeding they've had. Because if you took 3 drops of red food dye and put it in a big bowl, everything turns red. So patient sees a red bowl and they might have lost all of 5 cc's of blood and they're panic-stricken. Okay? Usually the patient, or sometimes the patient will know that a previous history of hemorrhoids. There, an anoscopy will give you the diagnosis. All right? Now remember, many people in this country have hemorrhoids because we eat our wonderful Western diet, high in red meats, low in fiber. We tend to be constipated. We're pushing. We tend to sit on our butts all day long, being sedentary. So we're putting pressure on these veins. So hemorrhoids is very common. So if you see a hemorrhoid and the patient tells you they have red bleeding, you can't automatically assume hemorrhoid, red blood, therefore patient has hemorrhoidal bleeding. How do you know the patient doesn't have diverticuli a little higher up? So if you make the diagnosis of hemorrhoidal bleeding, you better be sure that the question tells you on anoscopy there's fresh blood on the hemorrhoids. Okay? Merely the presence of hemorrhoids is not implicated as the definite cause of lower GI bleeding. Peptic ulcer bleeding and variceal bleeding. Again, let's talk about now how upper GI bleeds can present as lower GI bleeds. This is the key concept. If you have an upper GI bleed that's presenting with signs or symptoms of lower GI bleeding, such as maroon stool or bright red blood per rectum, okay? Is that going to be a big upper GI bleed or a slow upper GI bleed? Big. All right? Patients who have an oozing ulcer don't present with bright red blood per rectum, because by the time that blood wanders its way around the small bowel and the large intestine, by the time it gets to the rectum, it's black melanotic stools. All right? If you're going to imply that maroon stools or bright red blood per rectum is from a upper GI source, then what you're saying is that is a big upper GI bleed. And if it's a big upper GI bleed, you expect to see abnormal vital signs. So it is not compatible to label red blood as an upper GI bleed if the patient has normal vital signs. Okay? That rules out that possibility. If the patient is tachycardic, orthostatic, hypotensive, and has red blood per rectum, you don't know right then whether it's upper or lower. The history might give you some information. The physical might give you some information. Let's say there's epigastric tenderness, the history of NSAID use, the history of variceal bleeding, the history of alcoholism, the history of chronic liver disease. All makes me think whether there's brisk bleed with the unstable vital signs, whether that can be an upper GI bleed. And there I will always look for one clue, and there I go to the laboratory section to distinguish between a brisk, rapid, big bleed from the upper GI tract versus the lower GI tract. And there the giveaway will often be the BUN and creatinine ratio. A BUN creatinine ratio of greater than 40:1 in this setting is pathognomonic for an upper GI bleed. Okay? And that's because as the blood is rushing through the intestinal tract, some of that blood is being reabsorbed as metabolized to urea nitrogen, and so your BUN goes up out of proportion to your creatinine. Think about it. If I have a massive sigmoid diverticular bleed and that blood just pours out, from the instant it bleeds to the instant it ends up on the ground, that blood has traveled for 5 seconds. So the BUN does not rise. If you have a high BUN creatinine ratio in a patient who you're trying to distinguish between upper GI bleeding and lower GI bleeding, if you get this ratio, then it's an upper bleed.